Talley is a neurological surgeon in private practice and the chief of staff for Manhattan Memorial Hospital in Bradenton, Florida. He currently serves as the chairman of the Florida Medical Association's Health Information Technology Committee and is a member of the American Medical Association's HIT Advisory Panel, the American Association of Neurological Surgeons, and the Congress of Neurological Surgeons represents more than 4,000 United States physicians trained and certified in the specialty of neurological surgery. Welcome. You have the timer. We'll have 5 minutes. When it's going to have the green light, and then red means your time is expired. Welcome.
Thank you. Good morning, Chairman Matt. Good morning. Okay. Good morning, Chairman Velasquez, Ranking Member Chabot, and members of the committee. Thank you for inviting me to appear today to discuss the challenges small physician specialty practices face in adopting electronic medical records. My name is Philip Talley, and I'm one of 3 neurosurgeons in a small but full-service neurosurgical practice in Bradenton, Florida. I'm here, as you stated, representing the neurosurgeons. I've been the chairman, as you've stated, of 2 committees. I'd like to spend my time with you this morning telling you my story and about how we integrated electronic medical records into our practice, some of the challenges we faced, costs we incurred, and ultimately benefits that we've reaped both for our practice and our patients. In 1992, our practice was the 5th medical practice in the country and the first neurosurgical practice to go fully paperless. Implementing this new system was no easy feat. We could not simply plug in the machine and flip the switch. Because these systems are set up in a one-size-fits-all manner, it took over 1,000 hours to configure our system and create neurosurgical templates since there were no existing specially specific programs. All told, implementing the first system required about a year of prep time to purchase, configure, and implement. In addition, it took about another year to refine it and for our practice to become proficient with it. The costs of setting up and maintaining this system were significant. We spent about $50,000 on the initial setup. The system also required regular maintenance and upgrades, which cost us at that time about $5,000 a month. During the early years, our vendor continued to create new systems and upgrades. Every improvement resulted in some unintended consequence, which required a software engineer's time to repair. Implementing the system was particularly difficult on the staff, and not everyone was pleased to move to this new paradigm shift in our practice. These changes, coupled with the daily stress of working in a neurosurgical practice, simply proved too much, and we suffered a 30% staff turnover, as they'd had difficulty in adapting to and learning entirely new procedures and methods. This produced problems with continuity of patient care, loss of productivity, as we went through the process of hiring and training new staff. As our practice transitioned to EMR, we also had to keep the paper records for legal reasons. Interoperability was not even a concept at that point, and there was no talking between systems. Every paper document had to be scanned and transferred into the EMR. Notwithstanding these challenges, the physicians and our staff recognized the benefits of going paperless. The efficiency of the practice increased significantly. Staff no longer had to search for paper charts in order to answer patient phone calls, and they could quickly get information to the neurosurgeons. Our ability to quickly review and create new charts allowed us to spend more time with our patients. We improved our communications with other physicians since the completed patient record was never misplaced, always legible, and test results resided in a distinct folder within the EMR. In 1997, we converted to a Windows-based system, and we went through the same process again, incurring similar costs, downtime, and lost productivity. This new system was an improvement and significantly expedited patient care. Maintaining this system for the last 10 years has been a challenge. Hardware has failed, servers have been hacked, security requirements, particularly HIPAA, are onerous, and keeping a full-time IT employee in a competitive job market has been difficult. This year, we are once again in the process of converting to yet another new program and platform and incurring all the same costs as before. Even with our practice's lengthy history and experience with EMR, this upgrade has been a costly and difficult process with considerable loss of productivity. Furthermore, and notwithstanding our experienced eyes, after we purchased this system, we found flaws in the vendor's product. Madam Chairman, as you can see, our practice has been ahead of the curve in using EMR. Unfortunately, most physicians have not shared this experience, despite the fact that EMR has the potential To improve the delivery of health care, most physicians have been slow or reluctant to adopt these systems. A recent study found only 4% of physicians have a fully functional EMR system, so we have a very long way to go. And a 3 to 4 year timetable for nationwide implementation is optimistic at best. Perhaps the new e-prescribing provisions included in the recently passed Medicare bill will help encourage physicians to implement this entry-level mode of EMR. However, over 70% of the 3 billion prescriptions written every year are by primary care and emergency room physicians, currently the two groups with the lowest rates of EMR adoption. In addition, there are significant implementation issues such as the pharmacy familiarity, proposed and fatally flawed new rigid DEA rules for Schedule II drugs, which will make compliance by most neurosurgical practices very difficult. Congress can help pave the way to widespread adoption of EMR by passing legislation that will standardize interoperability and provide financial incentives to physician practices. We cannot rush this process or force physicians to adopt EMR using a stick approach, as this will only create more resentment amongst the physicians. It took over 10 years for the stethoscope to become widely accepted as a medical tool. While it will take time, we're on the right path in promoting this. There's general agreement that IHIT will improve patient safety, enhance quality care, result in more efficient practice, and better health outcomes should follow. We should not deviate from the premise, nor should we rush launching a complex system to satisfy political or administrative goals. Thank you for the opportunity to share my experience, and I'll be happy to answer questions at your discretion.
Thank you.